introduction. Now, what I'm going to do today is talk a little bit about chronic kidney disease patient and heart failure epidemiology, trying to give you a feel that this is a common condition. And there are two distinct things I'm going to talk about. One is chronic kidney disease per se in heart failure patients, and the other one is worsening renal failure in patients with heart failure when they are started on ACE inhibitor, angiotensin receptor blockers, mineralocorticoid receptor antagonists. So try and keep in mind that I will be talking about these two things. And then I will move on to the management, which is, as you all know, is quite tricky at times. And I'll try and guide you through the basic principles of management, show you where the evidence lies, but you'll be able to see that there is a lot of evidence gap. So what I'll do is I'll start off with two cases that I have recently seen in my clinic. And this is the first case, case 1, where you can see that this is a gentleman who was 79, was seen in our clinic with type 2 diabetes, chronic kidney disease with a GFR of 19, had quite a low ejection fraction, was fluid overloaded, also had gout and sleep apnea. He was 84 kilos and overweight. His blood pressure was 145 by 82, so that was satisfactory. His potassium was only 4.4. His sodium was 136. And the medications are listed on your right, which includes a beta blocker, a diuretic, a proton pump inhibitor, aspirin, pravastatin, hydralazine, isosorbide, and colchicine. This patient had an extensive history of coronary artery disease. As you can see here, that he had a bypass graft with a Lima to LAD, a radial to PDA graft at the same time, and a radial to RCA graft. He had an angiogram because of chest pain a year later, where it showed severe native disease, through which he went a stent insertion, and also had a CRT-D device placed in 2008. So you can see that ischemic heart disease was bothering him quite a lot. Now, his own examination when he first presented to our kidney failure, heart failure clinic, his JVP was elevated, he had edema, he had chest crackles, and he was short of breath on minimal exertion. So he had signs of fluid overload, and as you can see that he's on bumetanide 1 milligram once a day. When we looked at his blood tests, which were available to us when he presented, his hemoglobin was slightly low, his iron levels were low with a low iron saturation, the ferritin level was also low, B12 folic acid was normal. As mentioned, the creatinine was high with a GFR of 19. He had secondary hyperparathyroidism, and his BNP was elevated but not very high. Considering these are the medications that he's on, the question is, are you going to treat the anemia? And if so, how are you going to treat the anemia? Does it actually help? The second question is, what are we going to do about the diuretic dose? The patient has presented with shortness of breath. So one of the things that we need to do is relieve his shortness of breath to make him feel better. So that we can do by increasing the diuretic dose. But his GFR is only 19. So the question is, what do we do? And he is not on an ACE inhibitor. So is there a possibility that we can add ACE inhibitor to his therapy, which is going to improve his overall outcome? So that's the question to keep in mind. And these are the 3 questions to keep in mind with our first patient. Looking at the second patient, who also I have seen very recently, an 80-year-old gentleman with a coronary artery bypass graft, had an extensive aortic aneurysm repair in 2013, had coronary artery stenting once again in 2014, had another coronary angiogram in 2015. There was no lesions they could angioplasty or put stents in, so they left it alone. He's been hypertensive for quite some time. If you look at it, his electrolytes, his sodium is low, his potassium is high. So these are common problems that we see in our patients with chronic kidney disease and heart failure. Problem with sodium and potassium. And I'm going to touch on how to manage those and what are the implications of using medications such as ACE inhibitor and mineralocorticoid receptor antagonist. Now, interestingly, as the potassium went up, the general practitioner had actually stopped the Ramipril. So when he referred to us, his Ramipril was stopped. He was still on eplerenone, which was not stopped, quite surprisingly. And he was on bumetanide 1 milligram once a day together with bisoprolol. And you can see that his ejection fraction was quite low. He had hospital admission because of respiratory tract infection not too long ago, and he had an ACEi the year before related to his coronary angiogram. Once again, he was fluid overloaded with an elevated GAVP and leg edema. His chest was clear. So the question here is, before we move on to the question, let me take you through the blood test result. So his hemoglobin was once again low at 19.9. White cell platelets were normal. Iron levels were low. Iron saturation was low despite a high ferritin level, which we see in our patients quite commonly. And his creatinine was high with a GFR of 38. So the question, and here is his ECG. Now that's something which we look at regularly in our kidney failure, heart failure patients, because a kidney doctor and a heart doctor sits together, because we are looking for patients where the QRS is widened, or they're eligible for a device therapy in the form of ICD because of their low ejection fraction. So the question here is that, do you think this patient will benefit from a device therapy looking at the ECG that you have just seen? The other question that comes to mind is whether you're going to restart the Ramipril. Now, the GP has stopped because the potassium did go up to 5.3. Are you going to restart that? Patient is symptomatic, so are you going to increase the diuretic dose? If you're going to do either of these two, when are you going to repeat the use and ease? And again, the question from the previous patient and this patient is the same. How are you going to treat anemia? And I'll touch on the fact that heart failure patients do qualify for iron treatment even if they don't have anemia. Keeping those two patients in mind, how common are these problems? Now, they are quite common, and this is data that I have borrowed from the CDC, looking at the chronic conditions among Medicare beneficiaries. And you can see that heart failure and chronic kidney disease, right in the middle, are quite common in this population of over 65s in the United States. And so a combination of heart failure with chronic kidney disease is also quite common. Now, how common is chronic kidney disease in heart failure patients? Now, if you look at this slide, it's a large meta-analysis by Dr. Daman. You can see more than 1 million patients he put together, and chronic kidney disease prevalence is about 32%. And I'll show you data from St. George's, which is very similar, and most of the studies will have a very similar figure. So 1/3 of all the heart failure patients that the heart failure doctors see in their clinic are actually patients with chronic kidney disease as well. So this is not an insignificant problem. And these patients also comes with problems of managing their potassium, managing their creatinine while using ACE inhibitors, minerelocorticoid receptor antagonists. So you can see already a very complex patient who might require close monitoring. The other side of the story is worsening renal failure, which is a condition in heart failure patients whereby the creatinine goes up quite rapidly. And sometimes it's because of an ACE inhibitor or angiotensin receptor blocker use, which is potentially reversible and perhaps has a completely different implication to an acute renal failure because of sepsis or prolonged hypotension or interstitial nephritis. So try and keep in mind, though about a quarter of the patients do develop worsening of renal failure, there are a whole bunch of patients developing acute kidney injury because of sepsis, drugs, etc., and a group of patients whose kidney failure has worsened apparently after you've started an ACE inhibitor, angiotensin receptor blocker, etc. Now, looking at the patient population from the other side, how common is heart failure in patients with chronic kidney disease? And this is the data from a large German study with 5,000 patients, looking at a tool they used called the Gothenburg score as the prevalence of heart failure as the GFR goes from more than 90 to less than 30. And then you can see that as the GFR goes down, the heart failure as estimated by this score goes up quite a lot. And with a GFR of less than 30, you're talking about 50% of the patients having heart failure, either systolic or diastolic. Now, when you are in front of a patient with chronic kidney disease and heart failure, their main problems are symptoms. They are symptomatic, they are tired, they are lethargic, they are fluid overloaded, which requires careful attention and use of diuretics. But they do have multiple hospital admissions and a very high mortality, which I'm going to show later on. Now, this means if we're going to manage them, we have to manage their symptoms, which is very important for the patient themselves, but at the same time, try and reduce hospital admissions and death. So keep this figure in mind, please. Now, when you look at a population of heart failure patients, and this is a study from the general population in United Kingdom, echocardiographic heart screening study in West Midlands, you can see that patients who have heart failure with left ventricular systolic dysfunction or without left ventricular systolic dysfunction do have a very poor prognosis. Patients who have left ventricular systolic dysfunction on echocardiogram but hasn't presented a heart failure also has quite a poor prognosis as opposed to the patients who do not have any history of heart failure or do not have left ventricular systolic dysfunction. And this is a large study of 5,000 patients followed up for up to 10 years. Now, if you add chronic kidney disease on top of that, the prognosis is even worse. And this is shown in this particular slide, which is the placebo arm of the Everest trial. You can see that patients who have a GFR of more than 90 by this orange line has a much better prognosis than patients who have a GFR of less than 30 in this blue line. And the green line and the red lines are in between with GFR with CKD stage 2 and CKD stage 3. So this is CKD, no CKD 2, 3, and 4 or 5. So you can see that as GFR worsens, the prognosis worsens. Now, it is heartbreaking to see that in the dialysis patients, the prognosis is even worse, as shown in this retrospective analysis of 310,000 patients that we did from the USRDS database. And you can see that if you follow the green line from 0 to 60 months, that as time goes by, the mortality is very, very high and the event-free survival is very low. And you have very few patients left at the end of 5 years if you have congestive heart failure. What is also interesting is that when these patients get diagnosed as fluid overload or pulmonary edema, as shown here. So this is a very common phenomenon in dialysis patients, as you know, particularly after the weekend holiday period that they have before they come on their dialysis on Monday or Tuesday. That fluid overload does have quite sinister implications in the long follow-up. So the dialysis patients have a very, very poor prognosis. Now, if you look at other analysis of looking at prognosis in these patients with chronic kidney disease and heart failure, you see a mixed picture. You see a consistently similar picture with chronic kidney disease, but a mixed picture with worsening renal failure. Now, if you look at this large population with 78,000 heart failure patients, the baseline chronic kidney disease is associated with a 80% increase in hazard ratio for mortality. And that's very similar to what you see here as well. Actually, it's 134% increase in mortality with baseline CKD. But when you think about worsening renal failure, there are some studies which show that there is an increased mortality. But in other studies, which if you concentrate on this one by Dr. Clark, you can see that patients with RAS inhibitor therapy and developed acute kidney injury had a higher chance of developing worsening renal failure. But the RAS inhibitor therapy actually reduced mortality in the long run. So try and keep that in mind. Now, if you look at the Indian subcontinent, the data is limited, but this is a very nice study from Kerala looking at patients who are presenting to 10 hospitals, 1,205 patients followed up for 1 year. And you can see amongst these patients, the only 25% of the patients who have left ventricular systolic dysfunction actually receives optimal treatment. And by optimal treatment, the authors meant beta blockers, ACE inhibitors, and if necessary, minerocorticoid receptor antagonists. So it's only a quarter of the patients. And that does imply that the patients with suboptimal therapy has a higher mortality in a very short period of time. But this study was actually published in 2017 as a follow-up, and you can see at 1 year, the readmission rate is 30% and mortality is 31%. And it's much higher in patients who had suboptimal treatment as opposed to optimal treatment. So even in Indian patients, we see that the optimal treatment is very necessary to prevent long-term poor prognosis. And in this particular population, CKD was present in 18%. Now, we all know that ACE inhibitor therapy reduces mortality in patients with heart failure. And you can see this is from the AIR study looking at acute myocardial infarction patients who were started on ramipril or placebo. This is a very old trial published in 1993, but there is a clear 27% reduction in mortality with ramipril. Now, is it true for CKD patients? Probably it is, and I'm going to show you some data on that. Now, this is an important slide, and I want to spend a bit of time on this slide. Now, this is another ACE inhibitor trial, enalapril versus placebo, and it's a SOLVE trial, which I'm sure you all know about, which was published a long time ago, but this is a reanalysis. Now, what this has done is that reanalyzed the patients depending on 4 different groups. The first group developed no acute kidney injury or worsening of renal failure on placebo. The second group did not develop worsening of renal failure but on enalapril. And the last 2 groups did develop acute kidney injury either on placebo or on enalapril. Now, I would like to remind you, the patients who are on enalapril, probably they develop worsening of renal failure because of enalapril itself. As you know, it prevents the autoregulation in the kidney. Whereas these patients with placebo have genuine acute kidney injury because of sepsis and drugs, etc. And if you concentrate on this orange graph, looking at the survival at 1,500 days, as opposed to this gray one, you can see that the patients who developed acute kidney injury on placebo, that's because of sepsis or drugs, etc., had a much poorer survival compared to the patients with enalapril who developed acute kidney injury because of the enalapril itself. So hereby the author, Dr. Testani, is trying to distinguish between the acute kidney injury that we see because of enalapril as opposed to acute kidney injury due to other causes. Now, the reason we see this problem with CKD patients and heart failure is because of this kidney-heart interaction. So if you have a kidney failure and you have a poor heart, the ill effects of kidney failure are increased preload because of fluid retention, and also activation of the renin-angiotensin receptor axis causing vasoconstriction and increased afterload of the heart. So the kidney has a bad effect on the heart. And similarly, the heart continues to put pressure on the kidney by causing renal congestion because of right ventricular overload, and also causing renal ischemia because of low blood pressure and poor renal perfusion. So this vicious cycle, once it's set up, it's very difficult to break. Now, what do we have in terms of management? We have diuretics for symptom control. We have ACE inhibitor angiotensin receptor blockers. We have minerelocorticoid receptor antagonists and beta blockers. Now, these last 3 medications are definitely proven to improve survival in heart failure patients. And I will show you that there is some data in CKD stage, at least early CKD stages, but data is limited in severe CKD. So I'm going to discuss that in the next few slides. Now, this is the NICE guidance, which we follow in United Kingdom. And you can see that the NICE guidance for chronic heart failure with left ventricular systolic dysfunction does have angiotensin receptor blockers, minerelocorticoid receptor antagonists, as we would have thought, ivabradine for rate control, and implantable devices. So we have to think about all of these things when we are managing our patients with CKD and heart failure. And it is very similar, the European guidelines, which talks about ACE inhibitor and beta blockers as the first step in treatment of all heart failure patients, followed by minerelocorticoid receptor antagonists, and then the devices as they are necessary, or valsartan, sacubitril, and ivabradine as the fourth step. So all of these we need to keep in mind when we are managing our patients with chronic kidney disease and heart failure. Now, one of the issues that we have in our patients is a high potassium. And this is not uncommon. This is a large database from the VA looking at 245 individuals, 245,000 individuals. And you can see as the CKD progresses, the incidence of hyperkalemia, which is defined as a potassium of more than 5.5, increase quite dramatically. So what is the evidence in CKD? So as far as ACE inhibitors and angiotensin receptor are concerned, I'll try and convince you that we do have evidence in CKD stage 1, 2, and 3, and it should be used. But a problem arises when we have CKD stage 4 and 5 because of creatinine and potassium going up when we start them on ACE inhibitor or angiotensin receptor blockers. Beta blockers, we have, I think, reasonably very good evidence in patients with CKD stage 1, 2, and 3. The evidence in CKD stage 4 and 5 is limited, but I'll show you a study in dialysis patients and analysis in CKD patients. The minerelocorticoid receptor antagonists, they can be used in CKD stage 1, 2, and 3 with monitoring of potassium. But in CKD 4 and 5, it becomes tricky, mainly because of the hyperkalemia and rising creatinine. Angiotensin receptor blockers are very similar to angiotensin converting enzyme inhibitors, as I mentioned here. They can be used in patients with CKD stage 1, 2, and 3, but in 4 and 5, it needs to be closely monitored. Ivabradine, we do have evidence in CKD stage 1, 2, and 3 in patients with heart failure with reduced ejection fraction with sinus rhythm, already on ACE inhibitors and beta blockers. And we quite often use hydralazine with isosorbitol because they are quite renal friendly and they can be used without worrying about potassium and creatinine in our patients, particularly CKD stage 4 and 5. But the evidence is perhaps around the early CKD stages rather than the latter CKD stages. Now, very few antihypertensives actually show a mortality benefit in patients on hemodialysis, and carvedilol is one of them. And these are 114 Italian patients with dilated cardiomyopathy, randomized to either carvedilol or placebo. And you can see that over a 2-year follow-up, carvedilol was associated with better outcome than placebo group. And so these are dialysis patients with left ventricular systolic dysfunction and due to dilated cardiomyopathy. Now, when you look at the patients with CKD stage, earlier CKD stage and pre-dialysis, and this is from Dr. Chang, from the San Francisco Bay Area. And you can see once again that as far as death and heart failure hospitalization is concerned, the beta blocker use is definitely beneficial in these patients. Now, ACE inhibitors in chronic kidney disease patients, is it actually beneficial? Now, this is the SOLVE trial once again that I showed you previously, and looking at patients with chronic kidney disease as opposed to patients without chronic kidney disease. And you can see that enalapril does confer a benefit over a long period of follow-up. But these are mainly patients with CKD stage 1, 2, and 3, not many 4 and 5. Minerelocorticoid receptor antagonists. Now, this is emphasis trial, which is eplerenone after heart failure and heart failure after myocardial infarction. Now, what we should be aware of that if you're going to use a minerelocorticoid receptor antagonist, the potassium will go up. This is eplerenone arm. The potassium has gone up after starting compared to the placebo group, and the GFR will go down as compared to the placebo group. So, as you can see, the GFR goes down. But this study actually in CKD patients was associated with reduction in mortality, reduction in heart failure hospital admission, and reduction in cardiovascular deaths. So once again, we have seen that it does improve long-term outcomes in patients with chronic kidney disease. Does device therapy help? Now, device therapy is tricky in dialysis patients, mainly because of the risk of infection. And this particular analysis from the USRDS database, you can see that there may be a benefit, particularly early on with ICD therapy as opposed to no ICD therapy. So this is no ICD and this is the ICD group and this is a survival function, but at a cost of very high event rates and very high infection rates. The event rates are mainly driven by sudden cardiac death and cardiovascular mortality, which is in a very high risk patient, as you can imagine, is quite high. But the infection rates are very, very high as well. So that's something tricky. However, we need to keep in mind that despite hyperkalemia, using spironolactone, then this is the RAL study published in New England Journal quite a while ago. You can see that as soon as you start the spironolactone in these patients, and this study actually had quite a significant number of patients with CKD stage 3, you can see that the potassium does go up as expected. But no matter what the potassium is, the benefit, i.e. death rate per 100 patient years, is maintained very well in the spironolactone groups as opposed to the placebo group, even in high and low potassium ranges. So yes, there is benefits of using these drugs, but of course we have to remember that potassium will go up and we need to think about ways and means of managing that. Now, is there anything new on the horizon? Yes. So this is your potassium binder, patirimar. You can see that this is a very recent study on a very small number of CKD patients with left ventricular systolic dysfunction. So this is use of minerelocorticoid receptor spironolactone, minerelocorticoid receptor antagonist spironolactone in patients with CKD and heart failure, and whether using patirimar can maintain the potassium within safe levels. So by safe levels, they mean 3.5 to 5.5. And as you can see, by using a titrated dose of patirimar, you can maintain the potassium levels quite nicely in a large population of patients, going up to 91%. So yes, it is something which can be done in CKD and heart failure patients. Now, a few slides on diuresis. Now, remember, I started off by saying that patients with chronic kidney disease have a lot of, chronic kidney disease and heart failure have a lot of symptoms, and these symptoms are related to fluid overload. The fluid overload also prompts recurrent hospital admissions. So, treating that fluid overload does indeed control symptoms better, and patients have a better quality of life. Can do the things they wish to do, can walk around and stay away from hospital. Now, on top of that, probably diuresis is associated with improved survival as well. So this is a analysis from the Everest trial, once again, which is a tolvaptan randomized controlled trial. And what I would like you to concentrate on is the fact that hemoconcentration, which is this. So which means if you use a diuresis, the blood will be hemoconcentrated and the hematocrit will rise. So if the hematocrit rises more than 3%, so this is a more than 3% rise of hematocrit, you can see these patients survive a bit better compared to the patients in whom the hematocrit doesn't change or drop. So an effective use of diuresis is associated with improved mortality, cardiovascular mortality, and heart failure admissions. And this is in the placebo arm of the Everest trial. The diuretics were used as the physicians thought it would be used. And these patients all had an ejection fraction of less than 40%. So you can see in heart failure patients with decreased ejection fraction, use of diuretics does improve their survival in the long run. Now, we as renal doctors, we are used to ultrafiltration, using ultrafiltration machines either in ICU or outside the ICU. But there was a trial which was looked at maximum dose diuretic therapy as opposed to ultrafiltration in patients with chronic kidney disease in preventing kidney failure and weight loss. You can see the weight loss is very similar in patients with diuretic therapy, which is in green, as opposed to ultrafiltration. But the creatinine rise, which we saw with the ultrafiltration patients, was not there in patients who received furosemide. And in this study, maximum dose of furosemide used was 120 milligrams per day, together with, if necessary, metolazone 5 milligrams twice a day. So that is quite a large dose of diuretic that they used in some of the patients very successfully. So when we talk about diuretic resistance, we need to think about such doses of diuretics. The other thing that we as kidney doctors do, we have the option of doing peritoneal dialysis in patients with chronic kidney disease with heart failure. And this is one such study, very small study with only 25 patients. But one of the things that this study shows is a decrease in days of hospitalization after starting the peritoneal dialysis as opposed to before starting the peritoneal dialysis. You can see that there is a decrease in the number of hospital admissions. And there are other studies which are all very small in numbers, but when they were put together by Dr. Nunes in 2013, you can see that the PD was associated with decreased length of stay in hospital after starting of PD. So one of the things that PD patients you can expect from is slightly better quality of life, staying at home and not getting admitted to hospital. Maybe there is some improvement in their exercise capacity, and the GFR usually remains stable. What have we seen at St. George's? A very similar picture, and this is 1,056 admissions with 851 patients over 2 years. And the prevalence of chronic kidney disease at St. George's is as high as I have mentioned in the past, perhaps a little bit higher, going up to 47% of acute heart failure admissions. And what is alarming is that when we discharge these patients, we don't use the ACE inhibitors and the minerocorticoid receptor antagonists. We are very good with the beta blocker therapy. So no matter whether you have no CKD or severe CKD or moderate CKD, so this is CKD stage 3 and this is 4 and 5, we do use beta blockers quite efficiently because we are not worried about hyperkalemia or rising creatinine. But as far as ACE inhibitors are concerned, we don't do very well, particularly with the severe CKD patients. And we don't do very well with minerocorticoid receptor antagonists. And as a result of which, triple therapy is used only in 12% of the patients. And these patients have a higher mortality, which we have shown, and have a higher length of stay once again. So we've got a problem there. And one of the things that we noticed is that the higher the potassium levels are, so this is going from less than 4 to close to 6, the higher is the chance that nobody will go home with an ACE inhibitor or angiotensin receptor blocker. So 100% of the patients, you can see 100 to 90% and 100% here, if you have a potassium of more than 5.5, you will go home with an ACE inhibitor or a minerocorticoid receptor antagonist. So that is a problem. And what do we do with these patients? Do we see them in the clinic once again? And what we decided at St. George's is that we will provide multidisciplinary care in the form of a heart failure, kidney failure clinic, which will have a cardiologist, a nephrologist, and an anemia nurse. Now, the anemia nurse is quite crucial here because a lot of our heart failure patients, even if they don't have anemia, they do qualify for intravenous iron, which is in NICE 2017 and the European Heart Association guidelines. And we do follow that, try and keep the ferritin more than 200. So when a patient comes, they get to see the cardiologist who looks at their ECG, pulse rate, etc., and do the housekeeping things in cardiology. They get to see the nephrologist who looks at their kidney function, potassium, sodium, and prepare them for dialysis if that's necessary. There is a crosstalk, for particularly when there are decisions about putting an ICD, etc. And the anemia nurse, of course, give them the anemia. And all of these medications are used in that clinic, and we hope that this gives benefit with fewer deaths, improved quality of life, and fewer hospitalizations. The initial data from that clinic shows that intravenous iron is prescribed in a large number of patients. We do have a lot of teaching on fluid restriction, on sodium restriction, on potassium restriction with dietary therapy. We start ACE inhibitors or angiotensin receptor blockers in a lot of patients, and minerelocorticoid receptor antagonists in a lot of patients as well. And the patients do like it. They do mention that in a kidney clinic to have a heart doctor, and I don't have to go to a heart clinic, and everything is done together, is always very, very useful. So in conclusion, what I have said is CKD is very common amongst heart failure patients, and it's associated with increased mortality, which I have shown from the tolvaptan trial, the placebo arm of the Everest trial. I've also shown that acute kidney injury is associated with high mortality, but one thing I would like you to remember is that worsening renal failure by starting ACE inhibitors or angiotensin receptor blockers means completely different as far as long-term mortality is concerned, as opposed to acute kidney injury because of sepsis or drug use. The other thing I've emphasized, and showing the data from St. George's, and this is similar in all the other studies, is that agents which are beneficial, for example, beta blockers, ACE inhibitors, minerelocorticoid receptor antagonists, are not very well used. And the same is story in the study that I have shown you from India. So there is a need for improved services, and what I think is more important for these complicated patients is to have better collaboration between the heart doctors and the kidney doctors to provide the best care they deserve. I'll stop there and thank you very much for listening, and I'll take any questions.
Thank you very much, Devashish, for that wonderful and comprehensive presentation. Patients with heart failure.